welcome everyone. I'd like to welcome our board members and those presenting to the meeting today. This is our Health and Wellbeing board member. Also like to welcome anyone who might be watching this live event. The way that people can watch is through the MS Teams link, or they might be able to be watching online. We have people arriving as we speak. Just to let people know, you'll only be able to see board members and presenters on this call, and you'll be invited to speak as we go through the agenda. If you've got any questions, please use the raise hand function. If you're struggling with that, then I'm more than happy for people to get my attention in other ways. I don't want people to miss out on making contributions, but yeah, I'll be looking out for the raise hand function. This is also people can also watch this on the live broadcast, and it'll be available after the meeting as well. We hope that everything will go smoothly this evening, but as we have, even though we've been doing this for a little while, there's always room for hiccups, etc., or squeaky chairs, which I've just found out. I've got a very squeaky chair. So yeah, I think that's everything I need to say. Just a reminder that it's board members that can ask questions, but it is great that we have got members of the public attending this call, and we've also got some councillors present. But yeah, I think with that all being said, we can kick off and start the meeting. First on the agenda, we've got the Joint Strategic Needs Assessment update. So I'd like to invite Sarah Philby to present the slides.
Thank you, Chair. I will just bring up the slides. Hopefully you can see those now. So I should just introduce myself first. I'm Sarah Philby. I'm the Assistant Director Corporate Strategy, and the JSNA programme team sit underneath me, and I'm filling in for a colleague today, but please bear with me. One of the team is on the call, so if we get any detailed questions, I will perhaps draw Suk in if he's available. So just a quick reminder that in November, when the board last met, we agreed a different approach to the Joint Strategic Needs Assessment. So as a quick recap, we're required to produce a Joint Strategic Needs Assessment that identifies the health and wellbeing needs of our communities, the wider core determinants of health and disparities in need and outcomes. The intention is that the JSNA is an evidence-based to inform decision making. However, in quite a few places, that can be a static document that only provides that snapshot, a single point in time. So the board agreed that we wanted to have a more dynamic approach. And so we're producing what we're calling our JSNA Plus. And this JSNA Plus will support commissioning to reduce health inequalities, assess the current and future health and wellbeing needs of the local population, and improve service access and delivery. So our JSNA Plus is going to be made up of a series of needs assessment products, which will be regularly updated and developed based on business need. And they're going to be automated. So we're not going to get stuck with a PDF document that's capturing data at a point in time. We've got a fancy new tool that means that we're always up to date. So bringing us onto that fancy new tool is the Hanslow Data Hub, accessible via www.hanslow.gov.uk/data. It's a screenshot there, but I will do a very quick live demo, technology permitting. So the Data Hub launched at the end of last year, and it currently provides a common set of reliable core data across a range of themes. You can break that down. You can look at the Hounslow level, you can look at ward level, and you can look at sub-ward level, so down to LSOA, lower super output area. We have also added the primary care networks, so we can sort of map across to those, as it says there, custom area mapping functionality. And there is comparator data in there as well. Links to fingertips for colleagues who are familiar with that particular benchmarking service, as well as more recent publications from ONS on levelling up data. And we're adding to that bespoke JSNA Plus products. So I will just stop sharing that screen briefly and try and jump to the Data Hub so you can see it in action. Now, hopefully you can all see the Hanslow Data Hub and you'll recognise this screenshot. So this homepage provides a very, very quick overview, some key figures about the borough on the right hand side there, and then colleagues will recognise this, a map of the borough where we can also dip into individual wards. So if you click on a ward, and apologies, it does take a little bit of time to load because it's pulling live data through from national data sets, but we can look at a ward overview. So here we're looking at Hounslow West. And this pulls out a whole host of information on the demographics of the ward, the population as it says there, the economy, children and young people, etc., etc. Now, we can also look at different data by theme. So if I were to dip into here, children and young people, again, apologies for the slight delay, but this is then pulling up information across the borough rather than at ward level, although you can drill down into ward level, or as I said before, where the data is available below ward level. And that pulls up all the nationally and published data, nationally available published data for children and young people. Now, in addition to those overviews and drilling into ward level overviews, we can also create custom area reports. So we can aggregate data up, so we can show a couple of wards, or drill down into LSOAs, whether that's an individual LSOA or a handful of them. And what I will look to add here, just so that you can see it, so we've got the 2019 ward boundaries and the LSOAs, as I said, but we can also add here we go. If, for example, you just wanted to look at those 3 wards, you could then drill down into the children and young people data, the crime data aggregated at that level. What I won't now do is add the primary care network boundaries, but again, you can go through a similar exercise and aggregate up to look at that data at that PCN level as well. The other tool we have on here, which I won't demo just now, is the Data Explorer. Data analysts and commissioners may be particularly interested in that, but you can drill down into all the individual data points, metrics, measures on the site and explore those. We've also added to the tool our Covert Dashboard, which is available on the public website, which is also available here for ease of use. And then these were the other outcomes frameworks that I referenced earlier that we can access here. What we have started adding is our JSNA Plus products. So these are snapshots across various subjects, identified by officers based on business need. And again, we're pulling in here published data, but drilling into a particular topic in a bit more detail. So I've brought up falls in particular here. And as you can see, that pulls out information on Hounslow in comparison to the rest of London. And presents it in a variety of forms. Currently, we've got this group of snapshots, but I will return now to my presentation, you can see a whole host of other snapshots are in train. There we go. Okay, we're back here now, hopefully. There we are. So here is a list of all of the JSNA Plus products that have been completed or are in development since the board last met in November. So these ones, the population 65 and over, childhood weight, fuel poverty, youth crime, mental health, skills and employment and falls. You'll have just seen them already live on the Hanslow Data Hub. And then we have all of these which are prepared, being reviewed or in train. I'll particularly point out the 24 months on, Hounslow and the pandemic and the post-furlough impacts. Now, rather than a snapshot, which as it says here is quite a high-level, quick access on a page, sort of at a glance review of a topic, the Hounslow 24 months on will be an insight brief. So that's delving into a bit more detail, pulling out trends, key indicators, and a bit more analysis of what the data is telling us. We'll also be developing deep dives. So a really detailed report providing local context, performance, impact, bringing qualitative as well as quantitative research and exploring potential solutions very much in conjunction with commissioners. So that suite of products will form our JSNA Plus. And that JSNA Plus will form the data and intelligence which this board will use to develop its new health and wellbeing strategy, which I know colleagues will be talking about later on today's agenda. And as I said, it's all based on business need. We have a group of colleagues who consider what are those areas we need to look at, who are interrogating that data that's being pulled through those snapshots and insight documents to identify and then explore those areas that need further exploration. And so it's very much aligned to the ICP work streams, which again is later on today's agenda. You'll notice that one of the Accelerator projects is Falls, and obviously we've developed the Falls snapshot, creating that evidence base for action. Also in train is the pharmaceutical needs assessment, and I've already mentioned that suite of products will form the 24 months on Hounslow and the pandemic, which we can bring back to the board at a later date once that's developed and we can present some of those key findings. But yes, that's just really a brief overview of where we've got to. I've not delved into any of the data in any detail. Can do that if that's helpful now, but I think perhaps more helpful is to share the link to the Data Hub and the website and people to explore that in their own time. Really, really grateful for any feedback. This is a developing product, so we're shaping it now as we're developing these insights products and snapshot products. So yes, I'll stop presenting there.
Thank you, Sarah. It's really great to be taken through that together, and it encourages all to get really familiar. It's really important that we are using all the data available to us to inform our decisions and our strategy, etc. Yeah, and so I will take questions. I can see that we've already got a hand up from Kelly. So questions from the board, please, and I'll try and keep notice of the hands coming through. Over to you, Kelly.
Well, first of all, thank you, Sarah, for taking.
Sorry, could I thanks, Sarah, for introducing yourself. I should have asked everyone, please introduce yourselves when you first contribute. So if you could introduce yourself, please.
Sorry, Chair. Kelly O'Neill, Director of Public Health. I'd just like to say thank you, Sarah, for taking us through that, and just to say to the business intelligence team and Suk and his JSNA team, it's just been an absolutely mammoth task putting that together. And what it is providing, as Sarah did point out, is really live data. So the most up-to-date data on a sort of a rolling, so it allows it to be kept up to date, because we're dragging it from a national system, which isn't what the JSNA previously had done. So it was pretty much outdated before we'd actually got it published. And I think the important thing just to emphasise is that this is accessible to all our ICP partners, the voluntary community sector organisations, and to residents, so they can see all of this data. And I think as part of that, Suk and his team have developed a sign-off process where they systematically validate all of the information in terms of accuracy to ensure that what's presented is the best available data that we can have. So I think it's a starting point, as Sarah has said. It's really only been live for about the last 3 months. It's going to be an absolute rolling programme for the next couple of years to systematically produce the data and the products in a way that's meaningful to our business need, but also to really represent, what the issues in Hounslow are. And also, as we go through that sort of the agenda for today, what we'll see is it will be used to inform all of our priorities, which I think is and to be able to identify emerging new priorities, which a static JSNA wouldn't have done. So it's great. So well done, Sarah. Well done to your team. Well done, Suk and the JSNA team. Great work.
Thank you very much. Any other questions from the board? I can see that we've got a hand up from Councillor Eason, but I don't know if you're aware that the questions are just from board members, or if any of the panel want to make comments or contribute, but it's just board members. So anyone else?
Chair, if I may, sorry, this is Kay, your clerk. Just to correct you on that, I think because the Health and Wellbeing Board, although we're meeting in the virtual space at the moment, you can take questions from attendees if you wish. It's just that we need to know if you, for example, take a question from Councillor Eason, then I'll just enable his microphone. It's not that he's barred from doing so, it's at your discretion.
Oh, okay, thank you. In that case, sorry, I stand corrected. I'm happy for us to accept the question from Councillor Eason.
Okay, Councillor Eason, you should be able to use your microphone now.
Yeah, thank you, Kay. Thank you, Chair. Just a question about the JSNA snapshots and the equality groups. I see that most of the equality groups are covered on slide 5, but 3 of them are not. Religion and belief, sexual orientation, and gender reassignment. As I'm sure you're aware, the Equality Act does not have a hierarchy. All of the protected groups are equally protected. So what are we doing about those about data on those 3 protected groups? Thank you.
Thank you, Councillor Eason. I can see that Sarah has her hand up already, so I don't know if that was quickly in response to your question or something else. But I don't know if you're happy to answer that, Sarah. Oh, thank you very much.
Yes, my hand was up in relation to something else, Councillor Atherton, but I'll take that question first. Very, very impressed that you spotted up, given how quickly I put up that slide, and it did remind me that I meant to say something on that. Yes, you will have seen there was only 7 of the protected characteristics listed. Religion and belief was on there. I think it's just a typo that it doesn't include belief. It should do. So we've got those 7. Gender reassignment and sexual orientation are also being picked up. We have a page in development for them on the snapshots. The only reason they didn't appear on that list yet is we're waiting for the new Census 2021 data to come through in order to make that more meaningful, because there's very, very limited data available locally for both of those protected characteristics. So it is on the longer to-do list, which goes on well beyond that one slide that I quickly showed on the screen. So there will be a snapshot for all 9 protected characteristics. I can assure Councillor Eason of that, and happy to pick up separately if that's helpful. The reason I just stuck my hand up was one of the things I forgot to demo very quickly on the live site was in addition to that first homepage where you get an overview of the borough, and then the thematic areas, children, young people, deprivation, housing, etc. We will have going very, very going live very soon is a Hounslow overview, which again will just be that sort of one-stop shop, bringing together all of that information in the thematic areas, but at a borough level as well. So should we wish to, although we're trying to be more dynamic and live, we will be able to extract a PDF, which, you know, a report where we can say this is Hounslow as of whenever we hit print on it. So that function will be there in the next day or so. We just had a couple of issues with the site today, so we couldn't quite get it live for today's meeting.
Thank you, Sarah. Are there any other questions? Can't see any on my screen, so I think we can move on. So next we're going to talk about the ICP structure and the focus, and our presenters are Pauline Mason and Anne Stratton. Please introduce yourselves and take it away.
Hello, it's Anne Stratton here. I'm the Director of Clinical Services at Hounslow Richmond Community Healthcare Trust, but I'm also the lead director in Hounslow for the ICP. So what I'm going to do is just give you some brief overviews and just a reminder of some of the work we've given you before, and then Pauline will tell you more about the recent work we've got, and then Kelly will finish off telling you about some of the work in terms of focus. So I know Pauline's driving for me. Thank you, Pauline. So this is just an indication of how the ICP fits into the system working at the moment. So what we've got in North West London is an overarching integrated care system, which comprises all 8 boroughs and was all the North West London CCGs coming together to become one integrated care system. I am going to put a health warning on all of these terms. You will find new language used very soon because we're going to talk about integrated care boards, etc. in the future, but I will leave it with the terminology we're currently using for the moment. We sit underneath that as place. So we've got an integrated care partnership working underneath that, a smaller footprint, but there are 8 integrated care partnerships feeding into the integrated system. And the richness of the place-based partnerships is that we've got all the partners that provide care and support in Hounslow on that group. So that means we've got ourselves as the community trust, we've got the mental health provider, we've got West Middlesex Hospital, we've got primary care representative, and we've got the London Borough of Hounslow all as members on with that. And we've got a real drive in terms of making sure we're working with the voluntary care sector and also engaging with our residents. So that's the hierarchy. When I said names are changed, so just to let you know, at some stage you'll hear the term borough-based partnerships, but that is the ICP as we're currently discussing. So again, this is a kind of reminder slide about where our governance sits and how it relates to the Hounslow Health and Wellbeing Board. So as you can see, we have the Hounslow ICP Recovery Board. That board is chaired by the Borough Chief Executive, Niall Bolger, and there is a representative from Hrch who operates as the co-chair of that board. And we're there basically to make sure we're going in the right direction, make sure our strategy is appropriate, and to make any final decisions. And those final decisions come from work that's undertaken in the ICP senior leadership team that I chair. So that group is made of all those partners that I mentioned earlier. And basically, we are responsible for delivering the operational elements of the plans that we've got in place and reporting into the ICP Recovery Board. Worth just saying, we have lots of structures that support us in that. So at the moment, we've got a Chief Finance Officers group, and that's made up of representatives for all the trust finance directors, and is chaired by David Hawkins from Hrch. But basically they set the process for us and support us working out how we can move money through the system in order to support the work that is taking place in the projects that we'll tell you a little bit about. So that's where that group sits. Also sitting alongside, if you look on the right-hand side, you'll see the Integrated Primary Care Group and the system interface. So we've got clinical resource to support us in the work that we're doing. So we've got an MD role that works, a medical director role that works into North West London and ourselves. And we are looking at the moment at 5 clinical sessions and are working out how they'll work across some of our projects that we've got going at the moment. There's a really useful interface group as well, which has senior clinicians from all the organisations who look at pathways across the system, which is another really useful one for us. We will also be appointing a lead professional, and that will be non-medical posts that, again, will support the ICP and those project teams in the work that they do. And if you look at the diagram, you'll see how we relate. Obviously, each organisation has their own board that they link into. And so our senior leadership team also has an interface. So although we've got all the representatives on our group, we link into the work that would take place there. So each organisation has their own medical director, they have their own lead professionals, and there is a matrix working across to that. We then report into 2 areas, in effect, after in terms of the Integrated Recovery Board. One is into the Integrated Care system, where we report into the Local Care Board, which is basically the out-of-hospital strand of that work. And that's where we've set our priorities and we're monitored on that. And the other one is into the Hanslow Health and Wellbeing Board, yourselves as overview and assurance of the work we've done, particularly in terms of the your move from making sure integration happens across all organisations. Sitting beneath all of that is also all the projects that we've got. So we've got a number of work streams, which Pauline will tell you a little bit about it going forward, and there's quite a large number of them. But just a reminder, when we started on this journey, we did set out what our shared version would be to allow us to understand where all the work we were doing sat. And that was the design principles: engaging with residents, empowering residents, investing in prevention and working across boundaries. So fairly fundamental principles. But partnership working can be quite tricky, and we thought it was really important that we set out what our key behaviours would be as partners working together. And you'll see those here. I think they're fairly self-explanatory, but it was really important that we set those down very early on so that we could help ourselves in good times and in difficult times when we were trying to work our way through what we had to try and achieve. One of the things that's worth saying is we've been working for some time now as an ICP, but actually COVID really honed down where we needed to focus. And I think one thing that really was a step change for us as an ICP was the realisation of the real struggle we were going to have if we didn't all operate together in terms of the recovery for the whole of Hounslow post-COVID, or even in the middle of COVID. It's probably not just post-COVID. And so therefore what we looked at was what were the components of the work that we were doing that would really support some of that. So absolutely the primary care networks were really essential in what we were doing. They could localise any of our decisions and make sure we were really addressing some of those inequalities. Mental health and how we ensured we integrated the community support into those PCNs, but generally into the work that we were doing. A real push on having a home first model, so trying to get people home in the first instance and making sure whatever we did was in an environment that worked for them rather than in a hospital or elsewhere. Then we've got the community solutions. Again, this became really important, particularly in COVID, looking at how we could use some of those community-led solutions to really shape the way that we communicated in community and actually delivered some of our work. And last and certainly not least, given that we have a SEND inspection coming up, we really wanted to put a focus on children and young people and make sure we were really all focused on what we needed to achieve. And really underneath all of these strands have been those areas that support us in what we're doing. So pooling our resources has become really important. If we were going to make change in the system, we recognised we needed to be able to come together and say, where did we need to invest? And that was certainly something that we saw within our CFO group, and we've had some real changes within that's allowed us to start doing that work and support the projects we've got. Tackling inequalities is the golden thread through all of our strands of work, and so was one we really have called out in everything we do. And then there are those real support strands, which is how we make the most of our workforce, how we support Hounslow in terms of employing our workforce. There's digital and about seeing if we can do this in a more effective way that involves others, but also allows those partners to understand the information we all hold. And then there's communications and engagement and allowing that strand of work to take place. And Kelly will tell you a bit more about the inequalities strand, as I said, which is really important for us as we go along. As I said earlier, the integrated care system monitors in terms of our priorities. Now, this was quite a difficult one. All 8 ICPs are at very different stages of development. We're at the sort of more mature end of development. There are others that are really in the early stages. So what we decided to do was come up with 6 priorities that all ICPs would be dealing with, no matter where they were in terms of their development. And these are detailed here, so you'll see the kind of list that we do. Again, you'll see they're overarching and they do fit in with the priorities that we have identified, with specific mentions of some areas where we're doing specific work at this moment in time. I'll now pass you over to Pauline, who will explain the project that sit underneath all that infrastructure that then would report into the Health and Wellbeing Board.
Thanks, Anne. Good evening, everybody. So my name is Pauline, the Programme Manager for the Integrated Care Partnership. I will not go through this slide in great detail, but it's just to give you a sense of the breadth and scope of the work that we do have. So for each of those building blocks, essentially, we have a really large sort of work stream, really a package of work, and each of those has got a number of projects beneath it. For your information, we've provided the SROs, which are the senior responsible officers, and each of those SROs are actually directors who sit in the senior leadership team as well. So we've got some very senior oversight of those projects. And as well as that, we've got various officers from across the partners who act as the project managers for those pieces of work. So what the board decided, so the ICP board that Anne mentioned last summer, was that whilst that programme of work is really ambitious, some of the things that sit within that programme of work are probably longer term achievements. And so looking at impact and delivery are probably longer term, and what the board felt would be good would be, could we identify some areas that we really wanted to prioritise, both in terms of the fact that they're real problems that we have in Hounslow, but also what are the types of things that we could do faster. So could we do that? So the board came together for a bit of an away day last August, and using the criteria that I've set out there, identified from those projects what would be what we've since called our Accelerator Priorities. So what are the ones that the board really want us to prioritise? All those other ones have to keep going, recognising that they have been chosen because they are all areas that we need. But if we were to identify what our key areas are in terms of them being transformational, the benefits of working together as a whole system, and what we sort of call, I guess, knotty issues, what would those be? So the board identified the ones that you see there, that are the 6 identified. And then what the board asked the senior leadership team to do, because as I said, they're the senior officers for all of this, is to say, okay, if you identify these, what are the key things that you're going to achieve in the next 12 to 18 months? And what support do you need to do that? So if we're saying we want these to really accelerate and happen faster, what is the support that you need? Both in terms of staff resource, is it data, is it information governance issues, but also is there some money that's needed? So the senior leadership team did an exercise on that. That was then passed along to the chief financial officers to say, okay, so we've identified where we can accelerate in terms of our own staff and what we can plug in, but actually there's a gap here in terms of money. So the chief financial officers over November and December essentially identified between them a ring-fenced fund. So each partner is contributing, and that fund will be a pot of money against which these accelerator projects can bid for, in essence. So there will be a process in place. They haven't just been allocated that money, so those projects need to be able to demonstrate what are we going to do with it to achieve our outcomes. But this was a really big win for us, and I think it's a really positive step as a partnership because it's something that we've not had before now. The next two slides, and I know that members have received these, so they're quite dense, and I'm not going to go through them in any great detail, other than to say it sets out basically, it tries to give, there's much more detail behind this elsewhere, but it tries to give in a headline what the ambition is for each of those accelerators and what is likely to change. And what you'll see here is these are things that we've been trying to tackle for a while, but probably until recently haven't come together as a group of partners to really try this and haven't had some resource to put next to them. So these are areas that within the next sort of 12 to 18 months that we really need to crack. And when the project leads and the directors are putting forward bids for that pot that I spoke about, they need to be able to demonstrate that it will achieve what those key deliverables are that are set out. Worth mentioning in those is what you'll see there is, and Sarah referenced it earlier on, we have falls, we've got children and young peoples with mental health in particular, and that's recognising these long waiting times that we have for the neurodevelopmental assessments. There's a focus on older people because we've got dementia as well as falls, diabetes. These were chosen based on data as well. Underpinning everything, and the reason that we chose this as a specific accelerator priority is tackling inequalities through population health management. So what we're recognising is that in everything we do, not just these projects, but the ones that you've seen earlier on, we really need to be looking at our data and understanding where we can redress the balance, basically. That's probably all I need to say on that, and I think it's Kelly is up now.
So thank you, Pauline. I think the key thing is having heard about the development of the Instant Atlas automated data system and the JSNA, the accelerator priorities were very much identified based on data, insight and intelligence and reflect the priority needs in the borough. I think Sarah presented the falls, for example. We are a significant outlier, so that's why they have been chosen as accelerator projects. As the data and the JSNA does develop, this will really reinforce those priorities and take account of new and emerging health needs. So the JSNA is developing at pace, with the population health work of the ICP providing the basis for a refresh for the health and wellbeing strategy, and with a much greater focus on health inequalities, particularly the sort of focus on unfair and avoidable differences in health between different population groups and people living in different parts of the borough. The examples of next slide, please, Pauline. So we're going to just demonstrate some examples of the work that has informed us about where we need to target, whom we need to target, and for what purpose. So fundamentally, this is a very much a reducing inequalities approach. It's a so it's built on population health management, and the enabling workstream function of the population health prevention and early intervention group is really focusing on long-term conditions and developing a sort of a place-based needs focus on different communities, and then moving this approach once it's becoming a little bit more mature into wider ICP projects, particularly the Frailty Programme Board. And to be clear, so just what population health and population health management is, it's a whole system approach that aims to improve physical and mental health outcomes and reduce health inequalities within a defined group. If you move on to the next slide, this presents the framework which we work through in a very, very systematic way. So all of our projects move through this particular approach, and this template is based on the one that has been developed by the King's Fund. So the principles of this is using data to understand the problem, whom it affects, that segmentation, whom it affects and is impacted by the particular issue, and then to systematically engage with those people that are most effective to design and implement an intervention and evaluate whether those who most need the intervention access it and benefit from it. And then it moves around a circle of continual evaluation, continually moving around to try and work out do those people that most need that service really truly benefit from it, and really start to tackle those fundamental issues that have really been emerging. And what we're also doing is systematically putting training across the ICP of key officers who are working on this, so that we develop a very, very robust approach to putting it in practice. In terms of the next slide, examples of what population health has driven in terms of engagement, because engagement is absolutely fundamental to the way population health management approach works. In practice, we've used this on a small number of projects, particularly through the early intervention and prevention work stream, and on some of our work through COVID and the COVID vaccination work that we've done. So we've used it as part of engagement through COVID champions and COVID vaccine champions and the winter ready teams, the people that are talking to different communities about winter preparedness, getting flu vaccinations and COVID vaccinations. We've also used this approach on young people and their use of services, particularly sexual health services, and that's to inform a sort of a much more targeted uptake of those services by young people, and also to try and understand the perceptions of young people as they access or sort of intend to access different services, so that we can tailor those services to their particular need. And one of the work streams that we have done is to look at parent insights. So we've had focus group with parents and individual one-to-one conversations to try and understand why parents are more frequently accessing acute services when there are community services that are more that would probably be better place to support them, and to think about how do we transform our services in order that they're more responsive to meet the needs of people that for whom those services have been set up to respond to. Also, in terms of Section B, we've also been doing some engagement work with Age UK, particularly focused on the Frailty Programme, and using their Befriender services to speak with 1,000+ residents aged 65 and over to understand the impact of ageing and ageism on them, to listen and think about sort of advocacy services, to look at inequalities in service provision and developing the shape of the care system for people living with frailty and those who are living to older ages. That's a particularly work in progress. And fundamentally, one of the things we've really thought about is really trying to understand the impact of the work that we've been doing. And as we move to an agenda item next, in terms of sort of what has the health and wellbeing strategy done, this particular approach will really help us develop the new refresh of that strategy. So in terms of sort of monitoring and evaluation, really understand what our starting point is for each of the work streams that we're delivering against. So, for example, we've done quite a significant amount of work on the development of the alcohol care team and looking to understand what was our starting position so that we could measure whether the investment in terms of resource and time has really delivered solid outcomes, and whether that approach is the best approach for our population need. We've done the same for the falls prevention service. That's still work in progress, and trying to sort of establish a really solid starting point. And as you saw, as I say, from that insight document, we're quite a significant outlier. So getting really understanding who we target and how we make the best use of that emerging resource once we put that in place will be really key, considering the investment that we're making. And then, for example, we've talked about one new Hounslow service. Now, that's a service that's going to be re-procured in the next year. So really thinking about, are the people that we most need to target those people who would most benefit from a really targeted lifestyle intervention? Are they the ones that are accessing it, getting a good experience from it, and benefit from those services? And if it's not, how do we change the way that we commission this new service going forward? And as I've mentioned, the Winter Ready team, looking at the insights that they're developing when they're speaking to members of the public, and how do we change our sort of local vaccination and COVID services in order to really increase uptake, particularly amongst under-vaccinated communities. And happy to take any questions from anyone, from all three of us.
Yeah, thank you very much, Kelly and Pauline and Anne. It's really great to have the vision set out clearly at the beginning, and also to see how the data is being used to inform strategies and programmes, and then also to have a real clear understanding that these will all be monitored and evaluated properly. So hopefully we can achieve our bigger ambition around this big project. I'd like to take questions. If there's questions from the board first, I'll take questions from the board. I know we've already got a couple of hands up of our guests this evening. Any questions from the board? Okay. Oh, yeah, I've got Councillor Lillybath.
Hello everyone, hi, thank you for the presentation. It was really clear and found it really helpful. I just wanted to ask a question around the monitoring and the evaluation really, and it was just simply to ask, when are we likely to see any results or our successes, or maybe not such successful kind of outcomes, if you know what I mean, so that we as a board can kind of have an oversight on that? Because I mean, there's lots of really interesting stuff going on, obviously, with all the work streams, but as you alluded to earlier on, I mean, obviously some of the work streams and some of the issues and what we're trying to do, I think, you know, have been long-standing ones, haven't they? So it'll be really good to see. I know we've had discussions around quite a few of them actually over the years, but I'd be quite keen to see where we're making progress, or perhaps where we're not making progress, and what we could do. It would be good to be able to get to that stage to have some discussions around that as well. So that was just really general. And just a question is how I wasn't sure about, but I was thinking about this whilst you were doing the presentation. I know that our ICP are statutory setups, but how are boards compared across the country? Is there like a quality mark or something, if you know what I mean? Is that a silly question? Sorry. I don't mind who answers that.
Shall I start on the metrics? So basically, I mean, some things have already happened. So we've got some things underway. What we've done is we've asked all of our project leads to identify metrics and timescales so that we can actually follow through. So we can produce something that says this is when we're anticipating that should happen. I have to say it's not been super easy to try and get metrics, because we want to move to make sure that the outcome metrics are not just metrics that count things that don't really tell us whether we've had any impact or not. So that's in process. So we should be able to give you an idea of when we're expecting some of these to start delivering. Obviously, the whole idea of the accelerator is that allows us to bring some of those forward so that we can do that. So I'm fairly sure quite soon we can show you when those metrics are, and even if it's the kind of overarching timescales for some of that, I'm fairly sure we can do that. Just to give you, because I'm like you, we've been talking about some of these for a really long time, so it'd be just like good to see how we start moving to tackling, even if it's a part of it, we're tackling it on the way to Journey to the Whole.
Chair, I was just going to come in on that question. So the two questions. So firstly, sorry, my name's Martin Waddington. I'm the Borough Director for Hounslow CCG and the Director of Commissioning. So two things. I think Hounslow have taken a really positive sort of population health management approach to the vaccine programme. And what we're looking at is not always targeting the most amount of people, but our most vulnerable populations. And I was in Hounslow House the other day, and one of our clinicians who is leading on the vaccine was saying how the now bus that we have for vaccines was in a very quiet area of Hounslow trying to vaccinate our homeless population. And we managed to vaccinate 9 people, which was fantastic because that was 9 of our most vulnerable people. But in that numbers war, it doesn't look so good. So it's just a change of behaviour to say it's not always about numbers, but it's reaching out, understanding where our vulnerable populations live, and going to them and engaging with them and getting delivery. So there are some things around vaccine that Kelly and the team could share with you that are very much about us using this population health. How do we engage with people very differently to meet needs in a different way that we could share going forwards? In the other programmes, we can do that. But what I want you all to understand is we're using this already. We're engaging with our populations in a very different way. We're talking to much more vulnerable people, and it is making a difference on our services. And we will continue to monitor in that way. The second thing, just about Councillor's Bath on accreditation. So COVID has actually slowed down the creation of ICSs because the legislation now doesn't go through to July. Chris Hilton and Anne are probably more specialists in this area than I am, but so we're still in sort of trial format. There is sort of guidance on how you need to form your ICSs, but there isn't anything of gold standard or absolutely how it's measured yet, but I'm sure that will come. But there is quite a lot of consistency of what an ICS needs to be made up of. I hope that helps.
Thank you. Yeah.
Okay, any other questions from the board? Okay, in that case, thank you for your patience. I'll go to Peter Gordon next, please.
Chair, can I confirm that you can hear me now? Thank you very much indeed. I'm Peter Goulding. Thank you for allowing me to ask a question. I'm a chair of the Network Participation Group in Hounslow, and I am part of a group that look after all of the patient participation groups. My question is to Anne and to the rest of the board. I refer to page 4 and page 5 of the presentation, ICP governance. A key fundamental point that you raised, a fundamental component, is the involvement of residents. And I note in the ICP, unless you tell me otherwise, there is no resident actually involved in that governance board. We used to have a resident involved in that board. That was changed, and we were told that we as residents or members of the community wouldn't be formally in the board. And in fact, I don't think we have got any formal membership of the Health and Wellbeing Board either, because changes were made and the membership is restricted. So it's a plea really, at what point would we actively involve appropriate representation from residents and patients on the ICP and on the Health and Wellbeing Board? Thank you, Chair.
Thank you, Peter. Just to be clear, I should have given apologies at the beginning of the meeting for Health Watch, but they are the member of the board basically who will be representing and the views of the public, and they work really hard to make sure that they've got representative views from the public that they work with. But is there anyone else who'd like to respond to the first part of the question? Okay, I've got Martin.
Councillor Austin, I'll start and then others come in. So Peter and Barbara and others, residents and members of public who've always really been very supportive of us. I hear very strongly what you're saying. When we came through COVID, as you know, we were very clear that we didn't feel we had engaged in our population in the right way to meet the needs of our most vulnerable. And we have looked at that in a new way, as I was explaining earlier. And we really, Kelly and the public health team, the council and their community engagement and solutions team are really thinking about how we get out into our communities more and engage with them more. So it's not that we're not engaging our public with residents within the ICP. So there's a big piece of work around frailty that we're doing with Age UK to talk to our frail population. We're just working with West London Mental Health Trust and our voluntary community for people with mental health issues to understand how we engage people with mental health issues. We've got participation people doing a big project for the council to ensure we engage with young people in a much more dynamic way than we have in the past. And we have got the community champions and the whole people working on the vaccine to talk to our population about. So we are engaging well. I think what we do need to get better at, Peter, is I know Mark Jarvis attends the group you chair. It's that relationship between what we are doing and how we go and share that with you and explain how we're engaging our population in this new way to reassure that we are taking this very seriously. But I just want people to understand we are taking the voice of the residents of Hounslow, all the residents of Hounslow, very importantly in this, and we are engaging differently, which has changed the way we work.
Martin, thank you ever so much for that response, and I don't dispute anything that you say. The point that I raised, which I think you slightly missed, is that we don't have proper representation, we would suggest, on the ICP itself or on the Health and Wellbeing Board. You are certainly engaging the community in order to do the actions that you articulate, and we will support you and have continued to support you. We feel somewhat aggrieved, maybe too strong a word, but we do feel somewhat aggrieved that we have no representation on the ICP or on the Health and Wellbeing Board, and that is something that we would wish the board members to fully consider.
Thank you, Peter. I've got Anne who'd also like to respond to I think your question.
So I obviously hear what Peter's saying and the request that we go and consider it. So that's fine. I just did want to add into the ICP should have Health Watch on the ICP as well. So we do need to do that. But probably one additional thing, which again confirms what Martin's saying, as SROs of the projects that sit beneath us, one of the questions we do ask our project boards and will continue to ask or our project leads is how they're engaging, which is how we ended up with making sure that the frailty survey was going on, so that we actually could build that into the work for that difficult to reach group. So so we do hold all of those delivering to account for that.
Thank you, Anne. I don't think I'm seeing anyone else in response to that question. I'll take Barbara's question next. But please be mindful that this is the board meeting. So, but yeah, go ahead.
Barbara, your mic has been enabled. You should be able to switch it on now.
Okay, I think we might be having difficulty hearing Barbara. I will keep a lookout for your hand going up again, and definitely provide an opportunity at the end of the meeting if you are able to come back in. But otherwise, if there's no other questions on this section, then let's move to the next agenda item, which I think is Anne Stratton again, if I'm correct, talking about the Hrch partnership arrangements. Thank you.
Thank you very much. So this is really just to tell you a bit of a change to a partnership relationship. So those may already know that we've been since January 2020 operating with a shared chair and chief executive. It was interim chief executive, it is now permanent chief executive, which we've shared with Kingston Hospital. We are just about to move into the next stage of that working together, and that is a move towards creating a single executive team. So both organisations remain separate sovereign organisations, but we will share an executive team that work across both the hospital and the community trust. In terms of that executive, and in order to ensure that we have got community focus on both sides of our organisation, which is Hounslow and Richmond, within the new single executive structure, we have got a chief operating officer who's responsible for community services. So we keep that really clear focus on developing the community. We've also, and I can confirm now, although it was in the paper was indicating that we were considering, we have got a confirmed additional role, which is Director of Corporate Services and Integration. Again, that is to allow us to continue to be involved in the work that we do on integration as much as we have done in the past. The aim for working together is to actually allow us to do the work in the same ways that we've been doing with the PCNs in Hounslow, which is to develop a kind of richness of integration and provide additional opportunities for our staff, in particular in terms of staff development. But it's just to confirm we are still two separate organisations, although we will be working more closely together.
Thank you, Anne. So that is really just updating those on arrangements. So does anyone have any points of clarification or any questions? Not so. Oh, yep, we got Martin coming in.
Hi, Anne. Thanks very much for the update. Just really clearly, you are a very key partner for our ICP, and just some reassurance that this arrangement won't weaken that partnership and may bring more strength to it, but very keen just to hear your reassurance that's the case.
No, so absolutely. And one of the provisos on developing the community coup was to allow a community role, was to ensure that we still did operate fully into both our place arrangements, and certainly on the Richmond side they're not as developed as ourselves, and really are keen for us to continue developing in Hounslow because they really want to learn from us, so that's quite useful from our point of view. I think there's a real keenness to look at how we can do work together that might be able to move resources to support that. So, for example, I think in the conversations I've been having on the obesity agenda, for example, very similar issues that we're trying to deal with, and actually if we can have a solution that works in one, there is something about how we can look and see if that would work in another, bearing in mind all the things we've said earlier on about making sure we're really clear with population health management that we are tackling the right thing for the right people.
Thank you, Anne, and I can see that Mark Titcombe would like to also come in.
Yes, thanks. Mark Titcombe, the Hospital Director at West Middlesex Hospital. Thanks, Anne, for the note. I know we've sort of discussed this at various stages. And for the assurance, particularly that you've given around that, the Chief Operating Officer role, which will give that sort of community focus that you've described. Could you just say a little bit around, I know we've touched on this, some of the sort of more practical arrangements that will sort of be in place, in particular in Hounslow, in terms of that connection between sort of acute and community services effectively. I know we've got some examples of that, recently in terms of the discharge hub, etc. But it would be good to have that assurance, please.
Yeah, no, so that's absolutely, Mark. This doesn't and shouldn't take anything away from the relationships we already have, and certainly in terms of the work that we've done, in terms of the projects that we've got going on from ICP, but also the system ones that we do. So we will still be as involved in terms of discharge hub, currently the UTC, and any of the work we do together, like Falls, etc. within our. So there will be no change from that point of view. As I said, we've also got the role within there, which is an integrating role to allow us to do make sure we can continue to cover in the same ways that we do in terms of CFOs and also at the board level. So I'm hoping that we will, because I know you sit on both places as well, Mark, I'm hoping that we can actually cross-fertilise and see what works in both ways across both systems. So I'm hoping it will add rather than detract from either.
Thank you very much. Any other questions on this item? Barbara's got her hand back up, but I'm going to wait to the end because I'm not clear whether it's on this item or on the previous item. So if everyone's happy with that, we will take your question at the end, Barbara. We are moving on, and we're going to go back to Kelly, who's going to take us through the closing report for the health and wellbeing strategy.
Thank you very much, Chair. I'm going to take it that the report has been read, but I will just sort of stress some headlines and sort of go through the key points. So, as you know, the health and wellbeing strategy was initiated in 2018. It runs from 2018 to 22. So this is a timely draft closure report as we start to think about refreshing the strategy for what we will plan to do for the next 3 years. In that strategy, we set out a series of indicators under 3 strategic aims, which was start well, live well, and age well. And this focused progress towards improving outcomes against those 3 strategic aims was interrupted clearly by COVID. But actually, in terms of that strategic responsibility of the board to oversee the integration of services, what the COVID response did demonstrate is the journey and the distance travelled in terms of that integration agenda. And we've just picked up the sort of the ICP progress, but actually the ICP work in practice has been our COVID response. So the report does take account of the board's review of how it's functioned and the current reset to statutory membership in order to address the kind of the functional difficulties that were picked up as part of the series of interviews carried out by our policy team that asked attendees about the functioning of the board and the capability of the board to deliver its strategic objectives and its responsibilities. So we agreed through that process that we would reset the board for a period of 1 year, which is 4 meetings, in order to start to consolidate the work, refresh the strategy, and then think about what does representation look like going forward for the board, and taking account of some of the comments that Peter has made earlier on. So in the report, the statutory functions are stated, and I've listed what we've achieved against each of those statutory functions, albeit in the context of COVID. We discussed the JSNA today and the use of an automated data system. That's a responsibility for this board. And also you'll be aware that the PNA will be completed by the summer of this year after it's gone out for consultation. And we've talked about sort of looking at health inequalities through a population health management lens. So that's detailed in the report. You'll have seen the work of the ICP, and throughout the period of the last strategy received updates on integration. that those are key areas that the board has had oversight of and assurance from. And we've received and signed off statutory funding requirements, particularly in relation to the Better Care Fund. And there's also recognition that whilst the Health and Wellbeing Board didn't oversee winter planning, and the board in that period of time has never received a report on excess winter deaths, which is one of its statutory responsibility, there has been assurance through various reports of the ICP that there has been clear strategic and operational response measures in place, particularly at peak activity times around the winter, where it is clear that the organisations through the ICP have worked together to manage demand and keep residents safe. Also in the report is a RAG rating against those indicators, which are measures against Start Well, Live Well and Age Well, and where information was available, it's been stated as green, amber and red. And as mentioned, the COVID response has disrupted some of that progress. However, quite a significant improvement has been achieved in some measures. In other measures, there hasn't been improvement, particularly around weight management, and for domestic abuse, some of those measures were clearly, I couldn't get any measure to determine what the impact has been. I've also added a series of recommendations that should be taken forward to the next strategy refresh in order to make us more aware of what's been achieved as part of the next strategy. Pauline Mason and I are co-authoring that strategy because it's really important in the context of the ICP and the Health and Wellbeing Board that we recognise jointly that the needs of the population and how we're going to deliver against it. So we will have a draft strategy to the board at the next meeting, which is in June, which will show a clear link up between the board, the ICP and all of the delivery groups that are sitting underneath it, not least the delivery groups from the ICP, but also the delivery groups, the terms of reference, which we signed off at the last meeting. It's important to note that the next strategy will be a 3-year timeframe, and one of the things that we probably didn't really reflect in the last strategy was the context, the changing context in which we would find ourselves. So as part of that next strategy, we will build in periodic reviews to take account of any change in the local context, any emerging priorities from the JSNA we need to respond to. So a little bit more of a flexibility in terms of where our work is going to sit. And also the other things that we will pick up moving forward is a real oversight of performance. And Anne and Pauline have talked today about how the ICP is holding itself to account for clear outcomes and having clear baseline measures. One of the things that perhaps on hindsight, this current strategy didn't do is set out what our ambition was to achieve in terms of measurable targets. So having measurable targets, having oversight of performance and making sure as a board that our forward plan truly takes account of those areas through receiving reports on all of those areas will be part of the infrastructure of the way that the strategy is developed, with clear progress milestones and outcomes that are measurable, and to ensure that we have quite ambitious targets, because the ICP has set ambitious targets, and through that we should be doing similar. And the last but not least, in terms of one of the gaps that the last strategy had, is about the wider determinants in health, the impact of those underlying core priorities such as employment, housing, sort of the environment that people live in, that really determines what health and well-being looks like in our borough. So I think part of the strategy is to really reflect that health and services contribute to the outcomes, the health and wellbeing outcomes, but it's actually the environment and the communities that people live in which delivers much greater impact. So Paul, let's say in summary, Pauline and I are co-authoring the next strategy. We will take into account the context in which we are currently working and the vehicles including the ICP, that deliver many of our priorities. We'll make it sufficiently flexible so that it can adapt to a change in the context as and when that emerges. And we'll hold ourselves, we'll in the draft strategy, we will state some ambitious targets through which we'll be able to measure that we've achieved the success that we've set ourselves against those targets. So happy to take any questions with that report. But as I said, it was published with the papers.
Thank you, Kelly. I can see Councillor Lillybath has got a question.
Thank you, Chair. Kelly, can I just ask you a question around COVID and what the impact of it might be in the long run on the general population? I know it's very early days yet, but I'm thinking of those that might have pre-existing conditions and those that might be living with long COVID, and whether we have got enough flexibility to deal with that, or do we have I know it's very early days and I guess we don't really have an understanding of it, but I just wonder how that will look like in a couple of years' time. It may not have any bearing at all, but it may well do. And I just wondered whether whether we've reflected on that and whether there is provision within that, the work that the boards do.
Yeah, so Councillor Bath, so the current strategy talks about long-term conditions, and if you reflect back to 2020, we discussed the report that was done by then Public Health England on disparities in risk and outcomes of COVID. Well, in truth, nothing has changed. The same groups of people have been disproportionately affected, and they tally in terms of the health inequalities agenda. So the strategy clearly recognised that in order to make people healthier, we needed to reduce the risk of them getting a long-term condition. And then managing it. And actually the ICP infrastructure is predicated on particularly around the population health and early intervention work. It looks at different long-term conditions and how we reduce the risk of people being affected by them, but also looks in the context of communities and different groups. So moving forward, I think COVID is not gone. Regardless of any announcement, SAGE clearly states that it's going to be around for the next 5 years. There are going to be variants that do emerge, so hopefully the variants will dilute, and what we'll see is less aggressive forms of the virus. However, we can't absolutely guarantee it, and we need to prepare for that moving forward. In terms of long COVID, I don't think we've seen the true picture of long COVID. There are lots of people that are still yet to seek out health service and care. I don't know what we're looking at in terms of the numbers of people and that impact in terms of their ability to manage it themselves, or what that looks like in terms of their health and well-being moving forward.
Yeah, interesting. Thank you. Yeah, thank you, Kelly.
Thanks, Kelly. I just had a question. I am very confident in the co-authors of the upcoming report. Just wondered, do you want to wait until it's in draft and then receive comments, or is there anything you want, proactively before you write from the board? Do you want any contributions from the board, or is it best to wait till we see the draft first?
So Chair, we do have a timeline for the development of the document. We have agreed that we will do a draft by the middle of April. I'm more than happy to share an early draft of that document in advance of the June board meeting. But I suppose it's the timeliness of the elections that we're trying to sort of just make sure that those arrangements are robust. But so I think what we'll do is we'll share with the minutes of the meeting that timeline and the project plan for the development of the strategy and the scope of what we're aiming to achieve. And if there are any gaps that people find or the board finds is noticeable, please just drop either Pauline or myself an email, and we'll sort of include that where it's relevant.
Thank you, that's great. Okay, I can't see any other questions from board members, but I will take a question from Peter.
Thank you, Chair. Kelly, thank you very much indeed for your report and presentation. And I totally agree with you, and I'm sure all the board members do, about the performance and the measures to get the outcomes that we want to achieve. I think that's been the problem with a lot of health and wellbeing boards in the past, is we set the strategy, we set a goal, but it's actually tracking the work that's going on behind the scenes to achieve that outcome. And very importantly, where interventions are not achieving the outcomes that we want during the strategy, we're able to intervene and make changes, which I see as the Health and Wellbeing Board being such a key, because it's where all the partners come together, and we might all have to work together as a team to change our focus to get the outcomes we want, because the outcomes are not shifting as quickly as we would all like them to be. Thank you.
Yep. Thank you, Peter. I mean, I absolutely agree. I think, you know, it was a weakness of the last strategy, and possibly probably one of the weaknesses of the way the boards functioned in the past, is that we didn't receive reports on every single measure, and particularly those measures that were underachieving. But we will rectify that moving forward, and I think part of the review of the way that the board functions is to try and get on top of that. Certainly in the next, so what will be 2 meetings afterwards, after this one.
Thank you, Chair. Totally agree. And we will do everything we can to help, whether we are in the board or outside the board.
Thank you, Peter.
Thank you. Okay, and I've got, oh, thought I just saw one more hand flying up, but maybe not. So we've come to the end of that item, but I'll take the opportunity now to invite Barbara. Sorry to keep you waiting, Barbara, to come in.
I can unmute. First place, thank you. These reports were very interesting and very helpful, and it's information that we as patients have been wanting for a long time. What are the working groups and all of that, and we appreciate being able to see them. The thing I wanted to bring up is that I was disappointed that the focus of none of the working groups was on carers, and the 2011 census with extrapolated numbers says that there are about 24,000, maybe 25,000 carers in Hounslow. We will have 2021 figures soon. And I know that Nicola Bartholomew is working on a carers project, but it concerns me that there is nothing mentioned either in the JSNA or in any of the focus areas of the Health and Wellbeing Board that keeps our attention on supporting carers who support the most vulnerable in the community.
Thank you. I think Kelly wanted to respond to that.
Yeah, I do have a sticky hand, I'm afraid. Yes, Barbara. So in the detail, and I know that you've been working with Nikki, who works with me, is that in the detail in terms of the work on dementia, on falls, on frailty, and on care homes, while it's not explicit in the documents you've seen today, the needs of carers features quite significantly. And in terms of the resource allocation, as Nikki may or may not have said, we are, through a public health approach, we are really targeting the needs of carers as an absolute priority moving forward. I can assure you.
Thank you, Kelly. I also feel very assured, and the conversations and decisions that have been made in the last few years, and especially after the pandemic, I feel really positive that there is a real understanding of the needs of our carers in the borough, and there was a real recognition of how difficult the pandemic was specifically for our carers, and there's also a recognition around the wider social determinants of health that Kelly talked about, and that is all relevant as well for carers and the people that they're caring for. So yeah, please be assured as well that these questions are being asked, that the light is being shone in those areas, and if it's not explicitly there, then we can work to just make sure that our language really brings that out. But thank you for your question. And I think that means that we have no more questions. So we've come to the end of this formal agenda. The next is any other business, and haven't been made aware of any other business, but I will give this an opportunity for any board members who did suddenly have something burning that they wanted to raise at this point. I will look, and I can't see any hands. The date of the next meeting is June the 22nd, 2022. It will be to be confirmed, so keep a lookout as we approach the summer. Can't wait for that. So that is everything. Thank you so much again for your time, for your commitment to this meeting, and all your contributions. Have a good evening.
Thank you.
Thank you, Chair. Thank you.
Bye, everyone.
Bye bye.